Hello everybody, good afternoon. I'm sorry to disturb you with lunch. Please feel free to continue consuming calories. I saw that the first serving is very healthy. Don't know what's expected next. On behalf of Professor Weitz, Yoga Weitz, and myself, I think that we are going to start the session. First, I would like to ask if there is anyone here in the audience who does not speak Hebrew. Anyone who does not speak Hebrew?
Yes.
Okay, so we'll continue in English. My name is Pollak, and I was given the task to talk to you about the Dabigatran as part of triple therapy in patients with acute coronary syndrome or PCI or both and atrial fibrillation. What can we conclude from clinical trials and real-world data? My disclosures are that I was an investigator in all the AF trials, so I know the data from first hand. And I'm lecturing for the companies written here, and I get honorarium for that. So what is the problem? We'll try to define the problem managing patients with both atrial fibrillation and either acute coronary syndrome or percutaneous coronary intervention. This is the problem because we need to combine oral anticoagulants for atrial fibrillation with antiplatelets for acute coronary syndrome and stent placement. And the questions are, do we use 3 drugs, oral anticoagulants and dual antiplatelet? Can we use only 2 drugs, oral anticoagulants and single antiplatelets? How long do we use them? Excuse me. How long do we use them? And maybe there is one anticoagulant which is superior to the other. Shall we use the old warfarin, the new anticoagulants? Shall we choose by some criteria? So let's try and find out what are the data available. So it's estimated that about 30, maybe 35% of patients with atrial fibrillation will have or do have an indication over the course of the disease, which is a chronic disease and a chronic need for anticoagulation. They will also have coexisting coronary artery disease and may require PCI and be hospitalized with acute coronary syndrome. In Europe, it's estimated to be close to 2 million people per year who need a PCI in the setting of atrial fibrillation. So on one side, we have long-term anticoagulant therapy, which is essential to prevent ischemic strokes. On the other hand, we have the antiplatelet agents, which are essential to keep the stents open and to prevent myocardial infarctions in acute coronary syndromes. And as someone put it, we cannot win all. On one side, we need the dual antiplatelets to prevent stent thrombosis. On the other, we need the oral anticoagulants to prevent stroke. And they both cause bleeding, and you cannot simultaneously prevent all 3. This is a well-known and well-cited, I would say, registry done in Denmark and published about 5 years ago. And this has included 40,000 people trying to define what is the risk of giving antiplatelets and anticoagulants as single and combination. And you have seen this slide many times. And you see that if we label aspirin alone at a hazard ratio of 1, then clopidogrel alone is a little worse in terms of bleeding. Vitamin K antagonists alone are about the same. Aspirin plus clopidogrel is definitely with a higher hazard ratio for bleeding. Aspirin plus vitamin K antagonist even higher. Clopidogrel and vitamin K antagonist even higher. And the triple therapy is 4-fold the hazard ratio of just using aspirin or one antiplatelet alone. So So definitely we have a problem here. Trying to prevent events will be at the expense of bleeding. There are 3 megatrials of oral anticoagulants, warfarin or NOACs, or combining or evaluating warfarin against NOACs in patients with atrial fibrillation. Can we conclude something from these trials? Can we conclude about the combination of oral anticoagulants and platelets, and can we conclude which oral anticoagulant may be preferable in the setting of giving antiplatelet therapy to our patients? This is the first trial, first published, first done, the RELY trial, the Dabigatran versus warfarin. And as we know, we have a pointer, yeah. The Dabigatran 150 milligram twice daily was superior to warfarin alone for reducing strokes and thromboembolic events. The Dabigatran 110 twice daily was the same and was not superior, but certainly not inferior to warfarin. And this has come as a trial that basically all the following trials showed similar results. This is the Rocket-AF trial, the rivaroxaban versus warfarin. This trial has not reached statistical significance, but the trend is clear, and if you analyze the actual treatment the patients receive, not the intention to treat analysis, you also get a significant p-value. Namely, rivaroxaban reduces or is at least as good as warfarin to reduce thromboembolic events. This is the Aristotle trial, Dabigatran versus warfarin, same result, or the same, not the same result, but the same view of the apixaban being superior to warfarin to prevent stroke and ischemic embolism, systemic embolism. But to our question, we have a problem. The RELY was the only trial out of these 3 mega trials that allowed aspirin and even allowed dual antiplatelet therapy and its design. And more than a third of patients received sometime during the study antiplatelet therapy, aspirin, which was a dose less than 100, that was the requirement of the study, so small dose of aspirin. And some, not many, but some patients also received clopidogrel alone or actual dual antiplatelet therapy in about 5% of the population of the study. Both the anti-10A drugs, rivaroxaban and apixaban, did not allow the use of dual antiplatelet therapy. Clopidogrel was a contraindication to get into the study. The Rocket-AF did allow concomitant aspirin. About a third of patients did receive that. The Aristotle, again, about a third of patients were receiving aspirin, albeit in a small dose also, less than 165 milligrams, but clopidogrel again was contraindicated. So if we want to know from these studies or to elucidate any data about dual antiplatelet with oral anticoagulants, we just have the RELY data, which is what was into the study design. And this analysis of RELY was done. Danz has published that in Circulation in 2013. It's a very detailed analysis of those patients in the RELY study who received one of the 2 anticoagulants studied and at least 1 antiplatelet drug. As we said, about 40% of the study population. And now again, we are going to see a set of slides, but I will try and point out the important things. So the concomitant antiplatelet therapy in RELY, when given oral anticoagulants, be it warfarin or the Dabigatran, with an antiplatelet, you can see that in gray, the dots are without antiplatelet, and in red, the dots are with an antiplatelet. And we can see that the Dabigatran 110 remained as effective as warfarin in lowering the risk of stroke and systemic embolism, irrespective of platelet use. You can see that the P4 interaction is non-significant, and this is in part of what we showed at the overall study design, or study results. The Dabigatran 110 BID resulted in less major bleeding versus warfarin, irrespective of antiplatelet use. And again, this is along with the overall study results. The Dabigatran 110 resulted in less minor bleeds, overall bleeds, and most importantly, intracerebral hemorrhage versus warfarin, and this was also irrespective of antiplatelet use. What about 150 dose compared to warfarin and in the use with antiplatelets? So the Dabigatran 150 remained more effective than warfarin in lowering the risk of stroke and systemic embolism. But as we see, there is a trend, actually a very strong trend, toward a reduced benefit of the Dabigatran in patients on concomitant antiplatelet versus not receiving aspirin. You see that the red dots are much more on the equation line. And this has raised many questions, what these trend mean, and there is a criticism to the study which tries to explain that. I will point that to the end. Relative risk of major bleeding similar when antiplatelets were used with the Dabigatran 150 milligram BID or warfarin. Okay, so major bleeds were similar. And again, intracranial hemorrhage, we see that in all novel anticoagulants, intracranial hemorrhage is significantly lower compared to warfarin, and this was irrespective of antiplatelet use. Addition of antiplatelet agents to anticoagulant therapy did increase the risk of bleeding actually all over with any combination. So both warfarin, the Dabigatran 150 and the Dabigatran 110, when they are combined with antiplatelet in the RELY, which there is triple therapy is definitely associated with an increase, and even dual therapy is associated with an increase. But what you can see here is that out of all combinations, always the 110 milligram dose, always the 110 milligram dose with none was the smallest in any level of bleeding. 2.2 versus the others, 2.6 versus the other with no antiplatelet, 2.8 versus the other. So it shows that the 110, again, as we saw in the RELY study, in the overall cohort, was protective against bleeding compared to warfarin. As we know, when patients get into a study of oral anticoagulants, they may receive antiplatelets because their disease develops and they may need PCI or are hospitalized with acute coronary syndrome, but they don't receive the antiplatelets all through the study. So there need to be an analysis which adjusts for the time that the patient was on antiplatelet therapy. So that's a time-dependent analysis. Again, the antiplatelet use increased bleeding risk across all treatment. And even in a time-dependent analysis, we see that the absolute bleeding rate were lowest with the Dabigatran 110, and I pointed out the numbers. What are the caveats of such an analysis? First, there could be, and there probably is, an underestimation to the risk associated with full use of antiplatelet therapy, since the mean duration of use was only 2/3 of the total study duration. As I said, many patients went in and out of treatment with antiplatelet during the study. So they were not throughout the study on antiplatelet therapy, and when we analyze just the time or the influence of antiplatelet, we are looking at a shorter time period than the overall study. The thromboembolic benefit of the Dabigatran 150 BID compared with warfarin was attenuated when we added antiplatelet therapy, as I pointed out in the graph. And as I say, this is not readily explainable, and maybe that's a selection bias, because those patients who need also anticoagulation and antiplatelets are actually the sicker patients. They are the ones who come with myocardial infarction and need PCI intervention. And therefore, if you add antiplatelet, you are actually selecting or looking at this population with antiplatelet, you are actually selecting a sicker patient population where the Dabigatran 150 may not be effective or may not be as good because the sicker patient population also tends to bleed more. However, the Dabigatran significantly lowered the risk of intracranial hemorrhage even in combination with antiplatelet therapy. And that's, as I said, is a finding across all analyses and all data looked in those warfarin versus novel anticoagulant studies. The Dabigatran has the largest database of marketing. So we are talking now not about a study which is a study, a phase 3 with selected patients and criteria. Now we are talking about marketing data, and there is more than 200,000 patients in the United States itself that already received the Dabigatran, and these data can be analyzed from various databases. And I know of 6 analyses like that were done. I chose just to prevent them. One that was the Medicare database analysis. It was the largest one, more than 130,000 patients with almost 40,000 person years in follow-up and 2,700 primary events to be analyzed. So this is not a randomized group, this is real-world data, as we like to call that. Real-world data is what happens in the field once the drug is out. And in the United States, there are two combinations or 2 drug amounts with the Dabigatran. One is 150 milligram BID and one is 75 milligram BID. This is approved by the FDA. We don't have the 75 in Europe, we don't have the 75 in Israel, therefore I am going to disregard the data on 75 milligram, but let's just concentrate on the 150 milligram, and we can see that even in real world, the hazard ratio is 0.7, so 30% relative risk reduction for ischemic stroke in the real world, very much like the study itself. Major GI bleeding was more, as the study itself, by the way. I didn't point this out, but in the RELY study, in the overall database, not in the selected antiplatelet database, but in the overall database, there is an increase in GI bleeding with the Dabigatran 150 milligram, and this is also true when patients get it in the real world. Intracranial hemorrhage, again, a 70% relative risk reduction with a hazard ratio of 0.3, very, very significant as a protective compared to warfarin. And even a tendency to a mortality benefit, again, in real world, the Dabigatran in the RELY study had a borderline mortality, statistically borderline mortality benefit in the RELY study. Putting this in a graph form, this is the upper part with the Medicare database we just pointed out. They combined the 150 and 75, as I said, but it doesn't matter because 80% were on 150. And this is the RELY overall data. We see that the ischemic stroke was less with the Dabigatran compared to warfarin, also in the real world. The major bleeding was non-significant, but the GI bleeding was more with the Dabigatran 150, as we well know, also in the RELY and in the Medicare database. And mortality, as I said, was borderline in the RELY study and significant protection by the Dabigatran in the Medicare database. So even real-world data will show that the RELY data that we just analyzed and elaborated upon are probably holding well. With all that, we need to make some sort of generalized agreement. So the ESC consensus document published by the thrombosis subgroup in the ESC with many other collaborators, as you can see here, for management of antithrombotic therapy in atrial fibrillation patients presenting with acute coronary syndrome and or undergoing percutaneous coronary or valve intervention. So in this consensus document, which is a long document but very detailed, they analyzed all the studies that came out from the year 2000, all those studies which had a reflection of anticoagulation and dual antiplatelets. And they put it in a few tables, which I don't want you to read, just to show you that you can put a lot of letters in a very small space. But basically what they did is, this is the second table, they divided the decision upon which we are going to decide how to combine anticoagulation with antiplatelet by the Hasbled score. So the bleeding risk obviously has to be taken into account. So this is the table for the low or moderate Hasbled score, 0 to 2 points, and this is the table for the high Hasbled score. But they were kind enough also to provide a graphical representation of their conclusions. And what they say here, when you are going to look at a patient with atrial fibrillation who also needs antiplatelet because of an intervention he had, first evaluate what is the stroke risk for which you are going to give antiplatelets. And if the stroke risk is low, with a Charles-Bus score of 1, go to the left side, and if it's higher, go to the right side, because the higher the stroke risk, the more you would like to depend on anticoagulation and not only on antiplatelets, which you can accept under some conditions where the stroke risk is low. Step 2 is the bleeding risk, as I said. It's the bleeding risk, and you are looking at Hasbled, which is low, up to 2 points, or high, more than 3 points in each of the sides of the graph. And step 3, what is this clinical setting? Are we talking about an intervention with stable coronary artery, or are we talking about an unstable patient just hospitalized with acute coronary syndrome? And then in step 4, you are going to choose the antithrombotic therapy. The green O stands for oral anticoagulation, the A for aspirin, low dose 75 to 100 milligrams daily. The C blue stands for clopidogrel. And basically what we want to say is that there are conditions in which 4 weeks would be enough. Those who have acute coronary syndrome with high Hasbled score, you would like to be on triple therapy, but only for 4 weeks because of the high Hasbled score. Similar, when you have high Hasbled score in stable coronary disease and acute coronary syndrome in patients with a high risk of stroke, but then discontinue that and choose one of the antiplatelets in combination with the oral anticoagulation and continue that for the 12 months that we have to protect our patients after an intervention. And there are intermediate risks at 6 months and so on. So we basically can take most of our patients, try to fit them into this algorithm and see what, at least this is the recommendation of the European Society of Cardiology as 6 months ago. Okay, so the latest guidance for combination therapy, putting it in words, first, in general, the period of triple therapy should be as short as possible, followed by oral anticoagulation plus single antiplatelet therapy, preferably clopidogrel, or as an alternative aspirin. We are going to discuss that in a moment. This is a general recommendation. Long-term antithrombotic therapy with anticoagulation therapy with oral anticoagulation beyond 12 months is recommended in all patients, so those with atrial fibrillation have to continue lifetime oral anticoagulation. And where a NOAC is used in combination with clopidogrel and or low-dose aspirin, the lower tested dose of stroke prevention is preferred. So if we're talking about the Dabigatran 110 dose, we're talking about the rivaroxaban, the 15 milligram dose, which was actually not tested with antiplatelets, as I said, and the apixaban 2.5, the lower dose, BID, again not tested with antiplatelets in the Aristotle trial. So this recommendation of going for 110 is because what I showed you of the reduced bleeding risk with 110, and this was only tested at the RELY trial. Said all that, I think we are going to be facing a change in our practice. We're still talking about triple therapy, be it 1 month, 3 months, 6 months, but we are going to change that. The WOOS trial, which was presented a year and a half ago in 2013 and published in The Lancet, has taught us that continuing, or actually you can go pretty well by eliminating one of the antiplatelets. In the WOOS trial, it was the oral anticoagulant given with clopidogrel, and that was showed a significant reduction in major bleeding, as you can see on the left side of the slide, significant reduction in major bleeding, just going for an oral anticoagulant with clopidogrel, and no increase in thrombotic events versus triple therapy with oral anticoagulants and clopidogrel and aspirin. So no increase in thrombotic event. Actually, this p-value you'll see is significant, and on double antiplatelet therapy, you have less events, which are the MI, DACE, target vessel revascularization, stroke, and stent thrombosis, less ischemic events if you go for the oral anticoagulant in this trial with just a single antiplatelet, which was clopidogrel. And this was well discussed and is well known. The IZAR triple study is with the same idea, trying to see if we can go by just with a very short time of triple therapy, or just then in 6 weeks transfer just to one single antiplatelet with oral anticoagulant. This was presented at the TCT 4 months ago, and that was a 600 patient study given on the other side, as opposed to the WOOS trial where the patients were kept on clopidogrel and oral anticoagulants. In this study, patients were kept on aspirin and oral anticoagulant. So in one group of the randomization, 6 weeks clopidogrel and then just aspirin on oral anticoagulants, and the other group was 6 months and then stopped, meaning just aspirin and a single antiplatelet. This was the design of the study, just to make it more graphical, either short-term clopidogrel 6 weeks or medium-term clopidogrel 6 months on a basis of aspirin and oral anticoagulation for a whole year. And here again, the primary endpoint was not different. We are not protecting our patients probably better by continuing triple therapy long time. We are not protecting them. And looking at the analysis of bleeding, they did an analysis that involved minor and major bleeding together. You can see that in the group that continued the clopidogrel for 6 months, there was actually more bleeding. This is the gray group. There was more bleeding over 6 months as compared to just aspirin and the oral anticoagulant. And there are new studies coming in, and these are my final slides. Just something to look forward, trying to analyze specifically this question that I am addressing with you today. One study is called the Pioneer Atrial Fibrillation PCI study, which looks at rivaroxaban with or one oral vitamin K, with vitamin K antagonist, this or that, in atrial fibrillation. And this study is recruiting patients now, and we are going to see various doses of rivaroxaban in combination with antiplatelets to try and elucidate if it's safe or not and for how long. A similar study is done on Dabigatran. This is called the Redual PCI, and here patients are randomized to Dabigatran 150, 110, and to warfarin with clopidogrel or ticagrelor. And I didn't speak anything about the new antiplatelets, which for now are a big no in combination with oral anticoagulants. And the recommendation says that don't use new antiplatelets, namely prasugrel and ticagrelor, in patients who get oral anticoagulation. Just stay with clopidogrel. And in this case, this study, which is a pretty large study, is going to examine also ticagrelor as part of its group diversion. And with that, I conclude my talk, and I thank you very much for